we will have 6 presentations and followed by an question and answer session. So if you have any questions, feel free to type in or unmute yourself at the end of the talk. And by the end of this webinar, and we will have the Q&A and to discuss any questions you have or your questions for your future studies and policy implications. So yeah, so this is a special issue of the China CDC Weekly, and I believe this is the first one published by China CDC Weekly on the Alzheimer disease. And we know that Alzheimer disease is the most common form of dementia in older adults. And globally, over 55 million people live with dementia, and there are nearly 10 million new cases every year. The aggregate financial burden of the disease is over $1 trillion annually. As population aging accelerates, the need for a better understanding of the disease and for a better treatment, prevention, and care present an urgent and a major challenge to global health. So we will say that we will have 6 presentations, and we will put that in the order of country study, cross-country comparisons. The first 4 studies will come from a country study in China, in America, in the United Kingdom, and followed by 2 studies about cross-country comparisons. And we're fortunate to have this group of collaborators and from Yale University, New York University, Cornell University, University of Washington, and the London School of Economics, and Nanjing Agricultural University, as well as University of Cambridge, and many more. And this is, as I was mentioning, also a pre-conference event of a Global Labor Organization. So there are many exciting events ongoing starting from tomorrow, day 1. Today is day 0, but tomorrow there will be a celebration of 35 years of Journal of Population Economics. I'm fortunate to be part of the editorial board, and there will be a presentation of the new issue published for the January 2023. And it will also be a presentation of the Journal of Population Economics 2023 prize, and also introduction of the handbook of labor, human capital, and population economics. And there are plenty of sessions started with day 0 pre-conference event, which is about Alzheimer's disease. And we bring together David Card, Alt Galler, Jim Heckman, and others to talk about the past, present, and the future of population economics, followed by many events. So you're more than welcome to join the whole event of the Global Labor Organization Global Conference. So without further ado, so let's move to the first speaker, Dr. Hailing Yao, oh, I'm sorry. So the first presentation will be given by Dr. Zhuoer Lin about the geographic variation in inpatient care utilization, outcomes, and costs for dementia patients in China. So welcome.
Okay, thanks for the opportunity. Can you all see the slides?
Yes.
Okay, good. Thanks everyone. Thanks for the opportunity to present our paper. My name is Zhuoer Lin. I'm a 5th-year PhD candidate at Yale University. Today I'm going to present a paper, Geographic Variation in Patient Care Utilization Outcome and Cost for Dementia Patients aged 65 years or older in China 2017 to 2019. This is a joint work with faculties and colleagues from Yale University and Peking University. So here's the outline to this presentation. Dementia is increasingly a public health problem in the world. Currently, about 55 million people in the world live with dementia. The number will continue to rise rapidly, especially in low and middle income countries, which places a substantial burden on individuals, families, and societies. Considering both the direct health costs and the indirect costs of labor force, the global costs of dementia are estimated about $1 trillion annually, which is a huge societal burden. In China, the challenge from increasing number of persons living with dementia is especially serious. The overall prevalence of dementia is 6%, and representing 15 million people aged 60 years or older with dementia. Besides, there are also large geographic disparities across region, as seen in the right figure, where Western region has the highest dementia prevalence. However, no study to date has documented the national pattern of healthcare utilization, quality, and cost in China. The absence of knowledge will largely impede the effective allocation of resources for combating dementia and targeted policy interventions in China. Therefore, our study used administrative data from extensive national database to characterize the geographic patterns in healthcare utilization, outcome, and costs for patients hospitalized for dementia in China. So here is our study design. Our hospital service data were obtained through the Data Center for High Quality Hospital Management at Peking University Institute for Global Health and Development. The center integrates data for on healthcare service and management of representative hospitals in China for health policy and management research. The national sample covers 30 provincial level administrative divisions in China, making it the representative sample for understanding geographic variations. The data set spanning from June 2017 to June 2019 provides a rich set of information. And to ensure the care utilization and cost can be attributed to dementia, we include inpatient records with primary diagnosis of dementia based on ICD-10 codes. And since dementia is an age-related condition, we restrict our sample to those aged 65 years or older at the time of admission. And besides, sample with the respective 2% of the highest and lowest total inpatient care costs were excluded from the analysis to mitigate the potential influence of extreme values, and it is robust to other alternative criteria. Finally, about 2,000 hospitals in the database had valid dementia cases, with about 1,000 tertiary hospitals and 1,000 secondary hospitals below, and we in totally include about 50,000 total dementia cases in the analysis. So in terms of the measures, the inpatient care utilization is measured by the number of hospital admissions due to dementia per 100,000 person years, which is calculated by using hospital admission data, as well as the provincial population data at the age 65 years or older. And second, we evaluated the disease severity and urgency and outcomes of hospital admissions for dementia patients. Specifically, we used the percentage of emergency room admission and the number of comorbidities to reflect the disease severity and urgency of admission. And then we used the percentage of in-hospital mortality as an indicator for care outcomes. Third, we estimated the average total cost per admission based on the total hospital expenditure reported for each admission, and as well as the average length of stay and the average daily cost per admission to assess the care intensity during the hospitalization. For each outcome, we use a map to present the national level and provincial level estimates, and we use modern eye statistics to examine the spatial autocorrelation and the clustering. First, we will display the geographic patterns of inpatient care utilization, severity, urgency, and outcomes. So this figure shows the number of dementia-related hospital admissions per 100,000 person years for each provinces. The national average number of dementia admissions was 111 cases per 100,000 person years. The utilization rate of care was higher in Western provinces and some central and southern provinces such as Xinjiang, Yunnan, Guizhou, and Guangdong, but lower in northeastern provinces. There is some spatial autocorrelation and cross province is shown in the modern eye statistics, so the value is only marginally significant at 10%. This figure presents the percentage of ER admission among all dementia admissions. It's an indicator for care urgency and severity. The national average across provinces was about 20%, and some provinces with high percentage of ER admission include Shanghai, Beijing, Jilin, Guizhou, Qinghai, Henan, and Heilongjiang. No spatial articulation and clustering was found in this measure. This figure presents the average number of comorbidities per admissions as an indicator, another indicator for disease severity and disease burden. The hospitalized dementia patients generally had multiple comorbidities. The national average across provinces was 5.5 comorbidities. At the provincial level, the average number of comorbidities ranged from 3.1 to 9.5, and the average number of comorbidities in patients was higher in Western provinces and some Eastern or Northern provinces such as Xinjiang, Qinghai, Fujian, Zhejiang, and Beijing as compared to others. Again, no spatial correlation and clustering was found. Lastly, in terms of the care outcomes, this figure displays the percentage of in-hospital mortality among all dementia-related admissions. The national average across provinces was 1%. Northern provinces had the highest percentage of in-hospital mortality, including Inner Mongolia, Heilongjiang, Jilin, and Liaoning. No spatial correlation and clustering was found. And overall, we can see that the inpatient care utilization severity, urgency, and outcomes vary greatly across provinces, which may indicate notable geographic differences. And then we will further illustrate the patterns in average total cost, daily cost, and length of stay. As for the average total cost per admission, the national average total cost per provinces was about 14,000 Chinese yuan, which is equal to about 2,000 US dollars per admission, which presented clear geographic patterns at the provincial level. Notably, the average total cost per admission was highest among Jing metropolitan areas, including Tianzi, Beijing, and Hebei, and were consistently higher among more developed areas such as eastern or southern coastal provinces such as Fujian, Shanghai, and Zhejiang than others. The Morris eye statistics for average total cost were large and significant at 0.1%, indicating strong spatial articulation and clustering across provinces. This figure presents the average daily cost. At the national level, the average daily costs were about 1,100 Chinese yuan. At the provincial level, the average daily costs were higher among Jingxiang metropolitan area and some northern provinces than others, including Beijing, Tianjin, Hebei, Inner Mongolia, and Jilin. The average daily costs were also relatively high in some coastal provinces such as Shanghai and Guangdong. The Morris eye statistics for average daily costs were large and significant at 0.1%, still indicating very strong spatial articulation and clustering across provinces. Lastly, this figure further presents the average length of stay per admission. At the national level, the average length of stay was 15.5 days per admission. At the provincial level, the length of stay was highest among coastal areas in some western provinces, such as Fujian, Zhejiang, Jiangsu, Shanghai, Sichuan, and Guizhou. The Morris eye statistics for length of stay were also large and significant at 0.1%, indicating very strong spatial articulation and clustering across provinces. So in conclusion, our study demonstrated great geographic variation in patient care utilization, disease severity, urgency care outcomes, and the costs for dementia patients in China. There are several findings worth further discussion. First, the geographic patterns of the patient care utilization and costs overall were not entirely consistent with the patterns of disease prevalence, which may reflect the underlying disparities in dementia care and management. This pattern may be explained by the regional variations in the proportion of older adults, economic development, healthcare infrastructure, disease awareness and management, and varying level of financial burden and coverage for dementia care. Second, our findings of diverse geographic patterns suggest large gaps in health equity and efficiency for this fast-growing population of dementia patients. On the demand side, some factors include economic difficulties, disease awareness, social stigma, and other factors. On the supply side, some factors include access and quality of care, availability of well-trained specialists, and dementia care facilities, and criteria for dementia admissions and other factors. And finally, we showed that the cost and the care intensity were consistently higher among all more developed areas, indicating strong geographic disparities. As the demand for healthcare, nursing, and long-term care is intertwined, and there is a need to establish and strengthen primary care and long-term care systems and provide more affordable and equitable dementia care models in China. So our study still has some limitations which might imply from further investigations, further online hospital admissions with dementia as the primary diagnosis were included to ensure the utilization cost can be attributed to the dementia. But there's some issues exist, such as the misdiagnosis and misclassification, as well as some underdiagnosis of dementia. And second, the online mechanisms for the geographic variations were not fully explored. Therefore, one of our future steps is to utilize the data on local policy and practice and link with medical records to understand the mechanism of regional patterns. Moreover, in our future work, we will also examine the determinants of inpatient care utilization outcome and cost and provide more detailed estimates. Thank you for your time and attention, and thanks for the opportunity.
Thank you so much, Zhuoer. And let's move now from China to America. So we will have two presentations about in the American setting. The first one is from Dr. Yaoling Pei from New York University. Welcome. Yes, looks good, Dr. Pei.
Okay.
You may get started.
Okay. Thank you, everyone. I'm Yaoling Pei, a research scientist in New York University. Thank you, Dr. Chen, for organizing this special issue, and it is a great honor to be one part of this special issue. Today I'm going to present my own pilot study, Chinese American caregivers' attitude toward feeding for persons with dementia. This study is a study collaborated between New York University and University of Texas at Arlington. We have no commercial relationships to disclose. Extensive evidence showed that true feeding provide no benefits such as extending life and increasing nutrition status. And as a matter of fact, true persons with advanced dementia who used true feeding have poor quality of life compared with those using hand feeding. As a result, national organizations in the United States and in Europe increasingly advocate against the use of true feeding in persons with advanced dementia. However, Chinese American dementia caregivers may not know about this clinical evidence and this professional recommendation. According to previous studies, about 50% to 70% of Chinese individuals with advanced dementia used true feeding, which is much higher than a study conducted in the United States, majorly among white participants. The percentage is about 11%. Given that Chinese Americans are the largest Asian origin group in the United States, making up 24% of the Asian population, or 50.4 million people. So it is important to investigate Chinese American dementia caregivers' attitudes toward true feeding. So this study seeks to characterize the attitude toward true feeding based on a survey conducted among Chinese American dementia caregivers. In this study, we used data collected from 63 Chinese dementia caregivers living in New York City from November 2021 to June 2022. We used a purposive sampling approach. 114 participants were referred by 2 bilingual social workers in Carican, a community agency in New York City. Finally, we recruited 87 caregivers who are interested in our study. In this study, we excluded those whose care recipients had died and the 2 participants whose care recipients were using feeding tubes. The dependent variable is tube feeding preference in a half-sized context. I also measured the knowledge about tube feeding for individuals with advanced dementia. This variable is measured by a 3-item scale. The alpha for this scale is about 0.6. The sample items tube feeding is recommended for use when oral feeding difficulties arise. And the patient survival improves when feeding tubes are used, and the tube feeding improves nutritional status. We also measured if the caregivers know the wish of the patient with dementia. It's a 2 categorical variable, and 1 equals yes. In descriptive analysis, we calculated frequency for categorical variables, and we calculate a mean and standard deviation for continuous variable. We used logistic regression models to explore the factors that are associated with the selection of hand feeding. If the correlations with these of the variables are significantly correlates with the selection of hand feeding. So here is our pilot study results. In table 1, you can see that about 35% of participants selected tube feeding, while more than 40% of participants were unsure which one to choose. And about 90% of caregivers thought that they prefer to relieve pain and discomfort as much as possible, which indicating that many of the caregivers thought tube feeding is the approach to relieve pain and discomfort. Regarding tube feeding knowledge, you can see that this variable averaged at 0.41 out of 3, indicating relative no knowledge among these participants. Only about 16% caregivers reported that providers have discussed the tube feeding with them. In table 2, it's about the purpose of the tube feeding. You can see that more than 80% of the caregivers perceived prolonging life as one of the main reasons, and more than 65% of them perceived not to feel hungry or thirsty as one of the main reasons. In table 3, you can see that about 56% of participants reported that caregiver or other family member should equally make decisions on tube feeding. And when asked them, when do you think should make decisions on tube feeding, including the physicians, more than 50% of them thought that the provider or the family equally should make decisions on tube feeding. regarding which part is the most important one in decision making on tube feeding, we can see that patient's wish and the doctor's opinion are two of the most important ones that they selected. In table 4, we can see that actually about 70% of the patient didn't express in writing or in a previous discussion his or her wishes regarding tube feeding with family members. And more than 46% of caregivers are confident that the patient would not have wanted tube feeding if he or she is able to make his own medical decision. Table 5 presents the importance of food at the end of life. You can see that more than regarding the second item, you can see that more than 80% of caregivers thought that the provision of food at the end of life is a family obligation, and almost 78% of them thought that providing food at the end of life shows that the family has not given up. Interestingly, almost 50% disagrees that finance should play a role in determining if food should be administered at the end of life. Regarding the correlation analysis, we found that knowledge of tube feeding individuals with advanced dementia and having and allowing patients' wishes regarding tube feeding are significantly correlated with the selection of tube or hand feeding. And in the next step, we use the logistic regression to explore these two variables, the association with the selection of hand feeding. We found that two variables are also associated with the selection of hand feeding when controlling for age, education, and like insurance. So based on our results, we found that a considerable proportion of caregivers would choose tube feeding in the half-sized scenario. It is important to improve decision-making regarding feeding options among dementia caregivers and improve the advanced care planning. And we also found the cultural value of Chinese American dementia caregivers, such as family decision-making and finger obligation, may play an important role in decision-making about tube feeding. So based on our findings, we make a conclusion. It is important to improve knowledge about tube feeding and advanced care planning engagement, and incorporate Chinese culture are crucial for improving decision-making regarding feeding operations for Chinese American dementia caregivers. Thank you. I will take questions at the end of this meeting.
Thank you so much, Dr. Pei. And our third speaker will still present the work on American setting, and it's Dr. Namsang Choi from Cornell University. Welcome.
Hi, you guys can use my screen?
Yes, but not full screen.
Okay.
Yeah, now it's full screen. Thank you.
Okay. Nice to meet you. My name is Namsang Choi. I'm a graduate student in master's program for health policy and economics at Cornell Medical College, Cornell University. And it's an honor to have the opportunity to introduce our research. Our research title is COVID-19 Stay-at-Home Order and Older Adults Cognitive Health in the US. I'm
Hey,
going to
Dr.
start.
Choi, could you switch to the full screen mode?
Okay. So,
Yeah, thank you.
okay. Yeah, I'm going to start with a background. In the early stage of COVID-19 pandemic, most states in the United States introduced several precautions to prevent the spread of the virus. For example, the state of order required residents to stay inside their homes as much as possible and public stores to close down temporarily. However, these measures may cause an increase in social isolation and a lack of social relationships. In particular, the elderly is more susceptible to these environmental changes because they are not familiar with the new technologies that younger people use to communicate. And it is known that a lack of social activities in older adults negatively affect cognitive function and increases the risk of cognitive impairment, such as dementia. So we try to evaluate the impact of a state-specific stay-at-home order in the US during COVID-19 pandemic on cognitive health among older adults. This is our study design. We conducted observational retrospective cohort study. The study population included US adults aged 50 and older who answered UAS cognitive survey between June 2018 and February 2022. And we used the difference in differences analysis to compare the differential changes in cognitive scores before and after stay-at-home orders were implemented between states with and without stay-at-home order. And we used the two data sources. The first one is Understanding America Study, UAS survey data, which is nationally representative internet panel of over 9,000 adults aged 18 years and older. It began in 2014 and administered by the Center for Economics and Social Research at the University of Southern California. The UAS database consists of more than 300 individual surveys with over 50 survey modules on topics such as cognitive function, retirement planning, and economic status. And longitudinal studies are possible with the US data because its core topics are regularly performed. The other data source is US State Policy, CUSP database, which is a collection of state-level policies implemented during COVID-19 pandemic. It contains the start date and the end date of stay-at-home order and classifies the states into three categories. State issued the order, state issued the order but not restricted movement, and state without the order. Our independent variable was implementation of a stay-at-home order from the CUSP database. The treatment group is 40 states that have introduced the stay-at-home orders, and all orders were issued between March and April 2020. The control group consists of 11 states which did not issue any order or issued order but did not restrict movement of the public. Our outcome variable were 4 cognitive scores from numbers, picture vocabulary, verbal analogies, and serial 7 subtraction tests in the UAS survey. The first 3 cognitive tests were designed to measure the respondents' quantitative reasoning and lexical knowledge. The scores reported in the UAS survey were converted to standardized scores, where the mean is 50 and the standard deviation is 10. The serial 7 subtraction test involves subtracting 7 from 100 5 times in a row, and the score ranges from 0 to 5. These cognitive test surveys were fielded in 2 waves, one from June 2018 and the other from July 2020, which are before and after the stay-at-home orders were implemented, respectively. Now, here is our result. This table shows the numbers of states and personal observation for each of the 4 cognitive tests and the average test score in states with stay-at-home orders and without stay-at-home orders. During the study period, the total number of observations per panel was about 8,000, and of which over 80% were from the treatment group. The average cognitive test score was slightly higher in states with stay-at-home orders than in states without stay-at-home order in all panels. From the summary statistics by the exposure to treatment, the treatment state had higher proportion of immigrants and unmarried people and higher average education levels and household incomes. And to assess selective attrition between wave 1 and wave 2, we compared summary statistics by the number of waves the respondent participated in. Although we did not find large differences between those who participated in only one wave of cognitive assessment versus 2 waves, the former had a somewhat higher socioeconomic status than the latter in terms of education and income. This table presents our main result, which is the differential change in cognitive scores in stay-at-home order states relative to non-stay-at-home order states. As you can see, stay-at-home orders were associated with a decrease in numbers test and serial 7 subtraction test, and the increase in picture vocabulary test in verbal energy test scores. However, none of the associations were statistically significant. We also conducted a secondary analysis on subsamples stratified by age, gender, and either the individual lived alone. And the results were consistent with the main analysis. There is no statistical difference. So in conclusion, we did not find any evidence that stay-at-home order caused significant changes in cognitive paths of older adults in the US. This means that the cognitive health of older adults is not drastically affected by stay-at-home order, at least in the US context and in the short term. Our results also provide further support for some restriction measures to be viable public health options to prevent the spread of infectious disease. However, this result should not be construed to mean that all COVID-related restrictions would not impact the cognitive health of older adults. So further study is needed to understand the long-term impact of the restrictions and if there are more effective methods to mitigate unintended consequences. Our study had several limitations. The first, we are not able to observe the participant exact adherence to stay-at-home order. Second, there was heterogeneity in the specific nature of stay-at-home order rules across states, but we were unable to study each scenario separately due to insufficient sample size. Third, we are not able to examine long-term impact of a stay-at-home order due to the relatively short study period. First, the UAS sample was broadly representative of the US population, but participation in individual surveys were voluntary. So there is a possibility that those completing the cognition survey had a relatively better cognitive health, or that those who experienced a large decline in cognitive ability may have been less likely to participate in second wave survey. However, we could not find direct evidence that this is the case in the supplementary analysis. Finally, it is possible that COVID-19 illness may independently affect cognitive ability. Our study is one of the first to show that stay-at-home order did not have a severe negative effect on the cognitive health of US older adults. Despite of this limitation, we believe that our study would help public health policymakers to implement policies to respond to infectious disease in the future. Thank you for listening.
Thank you very much, Dr. Choi. And let's welcome the fourth speaker. And we will move to England. Dr. Bo from London School of Economics.
Hello, everyone. I'm really glad to have this opportunity to give a presentation in this launch event, and many thanks to Xi for the invitation. My name is Bo Hu. My presentation will be about the utilization of long-term care for people living with dementia in England. I would like to first acknowledge, first of all, some background information about people living with dementia in England. We estimate that there are around 676,000 people currently living with dementia across the country. We also our estimate is that the prevalence of dementia in the older population is around 7%. That is 4% among people living in the community, but much higher among care home residents. That is 3 out of 4 care home residents are currently living with dementia. Zhuoer just talked about the underdiagnosis or misdiagnosis of dementia. It seems to me that this is a common issue in different countries. Historically, diagnostic rate of dementia in England was not satisfactory. Around 10 years ago, this rate was only around 50%. Various steps and measures have been taken since then to address this issue. By the end of 2019, the diagnostic rate increased to around 70%, although unsurprisingly, because of the COVID-19 pandemic and the limited access to healthcare, this rate has been declining in recent years. Long-term care is crucial to older people living with dementia. Here, long-term care means hands-on assistance with the day-to-day activities, such as eating, dressing, cooking, and etc., all of which are valuable to people's lives. Long-term care enables people to live independently and helps to preserve functional capability that is consistent with people's well-being. I should acknowledge my collaborators here: Rafa Wittenberg, Alina, Thomas Herrera, Martinab, and Derek King. Sorry about the this slide. The important role of long-term care can also be noted on this graph, which shows the annual cost of dementia care for older people in England. Our estimate, and this is published evidence, our estimate is that the cost of dementia care is about £30 billion. And it is interesting to know that long-term care account for around 85% of the total dementia care cost. And the long-term care here includes formal long-term care and care provided by professional caregivers in terms of home and community-based care or care home services. This also includes informal long-term care, that is care provided by family members, neighbors, or friends. Our estimate is that it accounts for 40% of the total dementia care. This study looks at the pattern of care use in older people living with dementia in England. We look at this issue using 2 data sets. The first one is from the English Longitudinal Survey of Aging, ELSA. This is the English version of Charles, HRS, and Share. Collected between 2012 and 2018, we have a sample size of around 22,000. Using the method developed by Davis and colleagues, we identified 560 people living with dementia. One limitation with ELSA is there's very limited information around people living in care homes. So we also use cohort data collected in our MODAM project. Here, MODAM means modeling the outcomes and costs of dementia care, where we have a sample of around 300 people who were clinically diagnosed of dementia. Around 70 of them were living in care homes and 240 were living in the community at the time of the survey. This graph shows the probability of receiving home and community-based care among people with and without dementia. And this is based on logistic regression we control for a wide range of factors associated with care utilization, such as age, gender, marital status, living arrangements, education, housing tenure, and the functional disability. What we can see here is that for people with a similar level of functional disability, people living with the dementia has a much higher probability of using home and community-based care than those without dementia. Functional disability here is measured by the ability to perform activities of daily living and instrumental activities of daily living. We pay so much attention to functional disabilities because often it is the measure that is used in many studies to capture long-term care needs. And this graph here shows, this is also based on ELSA. This graph here shows that conditional upon receiving home and community-based care, for people with a similar level of functional disability, those living with the dementia use many more hours of care than those without dementia. Next, we look at the modem cohort data, and we look at the people living in care homes. Here, there's a similar picture. There's a strong correlation between the severity of dementia and the probability of living in care homes, especially as you can see here for people with a severe dementia. Their probability of living in care homes increased quite a lot. Conclusions of this study, there are two. First, we find that people living with the dementia, they have more complex care needs. Or another way to put this is that the traditional measure of long-term care needs, functional disability, ADLs and IADLs, may not fully capture the care needs of people with the dementia. And the second is that we found people living with the dementia are very intensive users of long-term care. And there are two implications. First, we know that age and dementia are strongly correlated. That is by this I mean the onset and the progression of dementia just increase rapidly with age. As the population continue to age, without further intervention and prevention measures, what we expect to see is that the prevalence of people with dementia or the prevalence of severe dementia will continue to increase, because we know that people with dementia are intensive users of long-term care. This means that demand for long-term care, we expect demand for long-term care is going to rise much faster among people with dementia than the general older population. So it is really important for the government to get prepared for such a shift in terms of care demand. And the second implication is that we know from previous evidence that more complex people with dementia people with more complex care needs, with high levels of care needs, they're more likely to have unmet needs. That is due to the complexity of care needs. It is increasingly more difficult to fully meet their needs. This means that care needs of people with dementia should really be carefully considered in the needs assessment process. This is important in many countries because many countries have needs assessment a step to determine eligibility for receiving, to providing support for people with dementia. So making sure that people's care needs are fully met is not only important to their well-being, to the well-being of people with dementia, it also protect people in terms of their health trajectories. What we know in the literature is that unmet needs is very likely to lead to accelerated progression of physical and mental health. So making sure that people's care needs are fully met can have an important and a protective role. So that is my presentation today. Thank you very much.
Thank you so much, Dr. Hu. And let's welcome our fifth speaker, Dr. Bingjian Yan from Nanjing Agricultural University, and he jointly worked with here at Yale School of Public Health and also Professor Thomas Gill at Yale Pepper Center on this research.
Hello, can you see my slides?
Yes.
Okay. Okay, hello everyone. It's my honor to be here to share my research. First, I will thank to my co-author, Professor Chen and Professor Zhuoer from Yale University, and my graduate student, Fang and Minlei from Nanjing Agricultural University. My presentation is about on the early life circumstance and the cross-country disparities in cognition among older populations, China, the United States, and the EU. The background is the global aging process is accelerating. In 2021, there were 1 billion people aged 60 or above, accounting for 12.7% of the global population. And the same proportion was 23 and 26.1% in the United States and the EU. And in China, this value in 2020 was nearly 20%. And with the accelerated aging across the globe, it is critical to improve health in older population, including in aspects pertaining to cognition. So by 2021, there was 55 million people worldwide will have Alzheimer's disease. And there are about 13 million cognitive patients in China. And the data was 6.2 million Americans who are 65 and older living with Alzheimer's, and about 14.1 million people in the European countries. And in the previous literature, we found that the growing scientific evidence found association between childhood circumstances and the cognitive health in old age. So my research question is, to what extent the childhood circumstances may explain cross-country disparities in cognition in older populations, especially between countries in different stages of development, such as the China, United States, the China, EU. And the data we used are 3 health and retirement study family surveys: the China Health Retirement Longitude Study, the United States Health and Retirement Study, and the Survey of Health Aging and Retirement in Europe. And our analysis was restricted to individuals aged 60 years and older, and no proxy respondents. We matched the life history surveys from these 3 survey data with their core surveys. So for the 3 HRS family surveys, the earliest and latest year in which cognition data were collected for this analysis were 2008 and 2018, respectively. And the important variable here is the cognitive ability score. To make the cognitive assessments more comparable across China, the US, and the EU, we measured cognitive ability using the validated mental state examination. And this score included the common dimensions and items across the 3 HRS family surveys, all ranging from 0 to 29. And the larger the value, the better the cognitive ability. And the early circumstances variables here were the war or farming experience, parental health, family SES in childhood, the childhood health, and the child abuse. The methods we used is the Osaka blind decomposition to estimate to what extent various childhood circumstances explained the differences in the cognitive ability of the older adults between China and the US, and between China and the United States. And a package IOP, equality of opportunity in data, was used to perform this analysis. Here is, we will see this figure that cognition status of the elderly in China, the United States, and the EU. Why the cognitive ability of the old adults in the US and the EU are relatively similar in this distribution that you can see is a normal distribution. And the finger displayed there are large gaps in cognitive ability with their Chinese counterparts. You can see Chinese counterparts who on average had the lowest cognitive ability. So why? What's the reason China has such a low cognitive abilities? Here is the summary statistic, and we will see that Chinese older persons had a significantly lower assessed cognition, that 8.9 out of the total score of 29, which smaller than their US and EU counterparts, respectively, at 16.5 and 17.5. And we can see that the years of education in this table, we can see the Chinese old adults in the sample also tended to receive low education, on average 4.5 years, with there are 12 years in the United States and 11.2 years in the EU. So education has been recognized a profound protective factor of cognitive ability. And we found that a significantly high proportion of Chinese old adults experienced war or famine compared to this in the United States and the EU. And we also found that when we use 5 levels of schooling were created across China, the US, and the EU to indicate parental educational attainment to harmonize parental education data for comparison. And there were significantly cross-country differences in parental education, specifically for older Chinese adults above age 60. About 60% of their fathers and 19% of their mothers received no formal education. By contrast, only 3% of farmers and 3% of mothers of the older US adults received no formal education. And we also found that similar differences existed when comparing other childhood circumstances, including parental and individual health. Chinese and European older adults experienced more abuse in childhood than their US counterparts. And here is the results from the Osaka blend decomposition. And we found, first, comparing China to the US and the EU, of all childhood circumstances respectively explain 65.4% and 38.2% of China, US, and China EU disparity in cognitive ability. And we see that family socioeconomic status measured by parental educational attainment contributed the largest, both in the China US and China EU. And we see the other factors like individual health, parental health, and the war or farm experience respectively explain a small share of the difference. So our conclusion here, we found using the data from 3 HRS family surveys conducted in these 3 big countries or areas, we found that childhood circumstances explained large share of differences in cognitive ability of older persons across countries. And first decomposition, those between country disparities, we specifically showed that the contributions of childhood circumstances amounted to 65.4 and 38.2% of the overall differences in cognitive ability in old age between China and the US, and between China and the EU respectively. And we found that the family's socioeconomic status was the largest contributor to the differences. So striving for parental education equality may compensate for disparities in cognitive ability resulting from other disadvantages in family socioeconomic status during childhood. And parental health status during childhood also contributed to disparities in cognitive ability. Father's lifespan explained much more statistically, but only slightly more in size to cross-country differences than mother's lifespan. And in addition to indicating inherited health endowments from parents, men's health explained slightly more, as they often constituted the main labor force and were expected to bring in major resources for their families. And overall, our main finding highlights the value of taking a life course perspective to study health inequalities. According to the economic theory of equality of opportunity, public policies aimed at narrowing the disparity between developing countries and their developed counterparts and promote global health equality should pay special attention to more equitable childhood circumstances and compensate for those who had adverse childhood circumstances. And the limitations of our research are, first, while this study used the comprehensive and harmonized MMSE for cross-country comparison, the lack of clinical diagnosis data prevented us from directly assess the link between childhood circumstances and cognitive impairment using validated clinical criteria. And second, the self-reported childhood circumstances data can be subject to record error. So that's all. Thank you very much.
Thank you, Dr. Yan. And that last but not least, Dr. Shanquan Chen from University of Cambridge, also a cross-country comparison. Welcome.
Yeah, for a moment.
Yes, looks good. You may start.
Okay, yeah. Yeah, thanks. Yes, today I will give a brief talk on the work collaborated with Professor Chen from for a moment. Hello, I'm still here?
Yes. Yeah. There might be some signal issue. Maybe you can turn off your camera so that give more bandwidth to the presentation.
Okay. Okay, for a moment.
Yeah.
Okay, I will.
Yeah, now it's great. Yeah, that's good.
Okay. Oh, sorry for the interruption.
No problem. Yeah,
I'm not sure what happened. Yeah, this is a work collaborated with Professor Chen from Yale University and with Dr. Zhang from Chinese University of Hong Kong. Yeah, first is the background. People living with dementia often use multiple medications to control their symptoms. However, the evidence indicated that polypharmacy usually associated with kinds of negative health outcomes, like unplanned hospitalization and frailty. And it was also estimated that the number of people living with dementia would increase sharply in the future 40 years. So all of this pose a potential challenge to the public health worldwide. To examine the trends or examine the variation of polypharmacy can be useful in design interventions. However, corresponding information in people living with dementia is limited. So the primary question we try to answer in this brief study is to answer what's the trends or what's the trajectories of polypharmacy in people living with dementia. We explore these questions using data from Share. Share survey is also a sister survey from HRS family. And in this study, target population was those who diagnosed with dementia, judged by a self-reported questions. Every doctor told you whether you have Alzheimer's disease like this. And we used the data from wave 6 to 8 of Share, which covering 2015 to 2019 because of the available information on the medications. We fit the data by country specific, which means we fit the one model per country. And in the logistic regulation and the outcome was the polypharmacy, yes or no. And currently, there is no single agreed definition of polypharmacy. So in this study, based on previous research, we coded those who took at least 5 medications as having polypharmacy. And the key predictor was the survival year, which is a continuous variable. And the confounders include age, sex, marginal status, education level, wealth status, and proxy. Proxy means that the questionnaire was answered by other people in the same household. And we also adjust a model using sampling weights to account for the complex sampling design. Finally, we included about 4,500 participants from 25 countries, and this is the percentage of polypharmacy in people living with dementia. Pro means we get the percentage by each wave and then meta them together. And from this figure, you can see the from the figure, you can see the overall percentage having polypharmacy and driving 2015 and 2019 varied substantially between countries, with the lowest rate in Estonia, about 20%, and the highest rate in Cyprus, and about 85%. And this is the percentage by country and by year, and you can see the big variations. And this figure show you the ratio extracted from the logistic regression, and from the figure you can see, driven among the studied countries, a lot of countries, the percentage of polypharmacy has no significant change, but Switzerland and Poland, Austria, and Czech Republic has significant increase in trends, where in countries like Spain, Estonia, Denmark, Bulgaria, and the Netherlands, they have a significant increase in trends. Our study primarily has 2 limitations. First one is we did not distinguish the appropriate polypharmacy and the problematic polypharmacy, because not all multiple medications was incorrect. And the second limitation is that Share has no information on the type of medications like antidepressant medicines or anti-dementia medicines. So this prevent us give more detailed explorations, and the future studies are recommended to focus on these 2 areas. Okay, finally is a brief summary. Yes, the first key point is that the polypharmacy for people living with dementia varied substantially. And some country have experienced significantly increased trend in polypharmacy for people living with dementia. And all results call for countries should pay special attention to polypharmacy and make efforts to control polypharmacy among people living with dementia, especially in countries where the trends has been increasing. Okay, thank you. It's short.
Well, thank you very much, Dr. Shanquan Chen. And yeah, now it's time for open up to questions, comments. If you have any, feel free to unmute yourself. And also, I encourage everyone to open your camera if you are able to. At the end, we will have a group photo. And as I was mentioning in the group chat, this is just the first issue of this ADRD by China CDC Weekly. And we are thinking of planning to do a future special issue or special articles next year during September, when it will be the World Alzheimer's Day. And we can also brainstorm ideas for special issues in other journals as well. So yeah, welcome. Any comments, any questions?
A question for, I believe, Dr. Choi about the US data showing no significant effect of COVID on mental acuity amongst older adults. Sounds like those surveys were conducted electronically. The data were gathered electronically. Is that correct? Or were they their phone calls?
Electrical devices provided to the respondents, so the data collected electronically.
Okay, so they may have been more savvy as regards electronic usage rather than, and that may have helped them, that population, fare better when things were shut down. Just a thought.
Yes, right. Thank you.
Yeah, thank you, Leslie. That's a great question. And also, I have a question about whether all those respondents are community dwelling older adults, or will there be any respondents from like nursing home setting? Because people may be affected very differently. Right.
Other question is for me. The respondent in the institution was excluded in the sample. So, yeah.
Mm-hmm. Right. Thank you.
Yeah.
Any further questions? And I also would like to ask every authors, presenting authors, since you already touched about some limitations and future steps, do you have anything further to share with us, your current work after this article you're publishing, and or you can share with us some exciting directions you are going to pursue or recommend others to pursue in the coming year? Thank you. We may start from Zhuoer, the first speaker.
Sounds good. So in this paper, we provide some preliminary analysis, also some descriptive evidence on the geographic variations in patient care utilization, outcome, and cost. In the future steps, we will try to associate it with some macro level data and some survey data to see whether some geographic attributes or some contextual factors may contribute to these geographic variations or some disparities. And another strand of work will focus on the determinants of these inpatient care utilization, mostly on the individual level characteristics. And we are working on like two projects on the individual level determinants, such as the insurance coverage, as well as some like the admission type, as well as comorbidities, and how these factors contribute to the inpatient care utilization cost and the outcomes after accounting for some geographic variations or some differences. We will like try to work on this project, and then hope this will be available to also. Yeah. Thank you.
Thank you. How about Dr. Pei?
Actually, this pilot study was collected for my K99 application. And I think my next step is to culturally adopt an existing decision aid to help Chinese American in decision making about feeding options, and pilot testing the effectiveness among this population. If get funded, and if not get funded, I will if I will maybe apply another funding or kind of mechanism.
Yeah, best wishes for that. And how about Dr. Choi? Do you have anything to add for the project you have been working on, or future directions of your other ABRD related projects?
This was our group project during the master's course, and we also examined the association between stage of order and the loneliness of the other adults. And we thought that the loneliness can affect the cognitive health, and it's also affected by the state of order. So, so we can, I think we can organize the research about the loneliness and this kind of restriction. Yeah.
Yeah, thank you so much for sharing further thoughts. And how about Dr. Bohu?
Hi. Yes, well, we are currently working on a project looking at inequality of long-term care for older people with the dementia. We know that usually people with the dementia, they're more likely to be to have lower socioeconomic status in terms of their education and income and so on. So one issue is that people living with the dementia, on the one hand, they may have the burden of the illness, the burden of disease. On the other hand, they may have the burden of economic cost of long-term care, as I have shown that long-term care just account for a large proportion of the total cost of dementia care, and in these issues, and this gives rise an issue of affordability of long-term care. That is how to make sure the long-term care system is properly designed so that people with equal needs, they have equal care, and make sure that their care needs can be fully met and that the services can be timely delivered. I think that is a major issue, I think, in the context of England, probably in many other countries, I guess. So that's me.
Thank you so much, Dr. Hu. And how about Bingjian Ye?
Yes, thank you. I think it's not easy to overcome the limitations in the recent research, because from the HRS family survey, there are no diagnosed data, and it's difficult to get the life course or life history data. But I have two plans. One plan is I want to study, because I found that education is contributed the most to the disparity across countries. So I think I want to analyze the mechanism of education on the later life's cognition, and also want to focus on the certain or one kind of the early life's circumstances. So this is the first plan. And the second plan, I want to do some simulation work, because we found that now the early life course maybe not very well in recent days in China. So I want to simulate if we improve the childhood circumstance now, what will happen? What's the benefit we will get in the future years? And so, yeah, that's my not very mature ideas. Thank you.
Thank you so much, Dr. Yan. And how about Dr. Shanquan Chen?
Yes, in the presentation, I mentioned the two limitations, and one is the distinguish between appropriate polypharmacy and the problematic polypharmacy, and the second limitation is distinguish the different type of medications like antidepressants or anti-dementia medications. And now, yes, in our team, we are trying to overcome these two limitations based on the data from clinic. And we, for example, and we also use start-stop criteria published by UK to judge whether the medication used is acceptable. And we also try to focus on the subtype of medications, especially for focus on medications which has effects on central nervous systems. Yeah.
Thank you so much, Shanquan. And I think there's an additional question for Zhuoer. Pepe Fu asked, what do you think the impact of health policies like the insurance type or insurance coverage on the findings, like geographic variations?
Thanks very much for the question. So insurance coverage for dementia care is a very important determinant of the inpatient care utilization outcome and cost. And in our ongoing work, we have examined the association between the insurance coverage and the as well as the outcomes, and we show very strong association between these two. And the amount of the insurance coverage matters a lot for the inpatient care utilization and outcome as well as the cost. So yes, you're right. And so it has a very large contribution to the overall findings. So and we will try to get it published soon. Yeah.
Thank you, Zhuoer. And I would want to add there's a few findings we have. Well, one very striking is using the inpatient data in China. We find that those who are having covered by a less generous insurance, they tend to get treated in a later stage. Like they tend to like going through the ER, which means that their disease management may not be as good as those have a better coverage. So insurance coverage really have some impact on people, the stage of disease they have when they seek care. Any other questions, comments? Yeah, I think we are running out of time as we scheduled, and I am very interested and amazed by everyone's research, and especially from the 6 research papers, you see that how large variation across countries and within countries. I think that suggests that we can learn from each other across countries for some countries to learn from others to do better, and even within a country, some provinces or regions can learn from others to try to improve their care and prevention. And all the 6 studies, if you check the titles and the contents, they are all focused on the care and prevention, but there's no much study about treatment effect. So I think this area is very promising in the future. We not only need to improve the quality of care and the prevention, but also how to treating those patients once we have more successful clinical trials ready. But so far, we don't have so much good news on that front. And thank you, everyone. And I think this is a very successful session, and I hope to bring together everyone's ideas and to have future discussions about the next step, what we can do together and to join force to improve the scientific studies of this field. Thank you, everyone. Have a good day and good night and good afternoon, good morning.
Thank you very much.
Thanks,
Thank you.
For organizing this.
Thank you.
Bye-bye.
Good evening.
Bye-bye.